Hello, good evening, everyone, and welcome again to yet another session on endometriosis awareness with me, Dr. Shilpa, and Dr. Vimi. Dr. Vimi, hi.
Hi Shilpa. Hi Amy.
And we have with us the wonderful Amy. So, welcome, Amy. It's like a pleasure having you on our platform.
Thank you so much. It's really a pleasure to be here today.
Absolutely. So, for people who have joined us for the first time and don't know what endometriosis is, it is a full body condition. It is a full body condition in which cells similar to those in the endometrium, not the ones of the endometrium, the layer that actually lines the uterus, cell similar to that covers, that grows inside and out, grows outside the uterus, anywhere else in the body, not just, the reproductive organs. Most often, this is on the ovaries, fallopian tubes, and tissues around the uterus. But saying that, as I just said, it's a full body condition. It can happen anywhere in the body, right from your lungs to your brain. 1 in 10 people, the female, assigned female at birth, have endometriosis. So trust me, that is a massive 176 million people worldwide. So being diagnosed and living with endometriosis can actually, affect your emotional health. From your reactions to a diagnosis that it's a chronic disease and it's something which will stay with you for a lifetime. And learning to live with endometriosis, the feeling of sadness, the depression, anxiety, and the changes to your body image can actually impact your life completely. Today we have with us Amy, and she was diagnosed with endometriosis at 33, 16 years after her symptoms began. She is an endo-advocate, and she's a content creator of the popular podcast in 16 Years of Endometriosis. Amy is also the author of Finding Peace with Devastating Disease. It's a beautifully raw and honest collection of 76 reflections on acceptance, meaning, and self-compassion. On Amy's website and Instagram handles, you can actually find the correct information and resources about endometriosis. You can follow her website on a website in16years.com, and her Instagram handle is at in 16 years of endo. She has not only helped herself but also touched lives of thousands of people suffering with endometriosis and related problems in by creating this book and the podcast which she runs with her best friend Brittany, which they talk about a lot of topics like practical tips, facts around the disease, common treatment and management options, resiliency, acceptance, and much more. Though the topics are extremely serious and painful, but they make sure that they make fun they make fun when you're learning about it. So Amy, welcome.
Thank you so much. Thank you for such a nice welcome.
So, Amy, to begin with, why don't you just tell us a little about your growing up years? Maybe how it was when you started having your periods.
Yeah, sure. So I actually got my period pretty late. I think I was about 15, but I remember being the last person of all my friends to get my period. And, I really was like, oh, when am I going to get my period? And little did I know what was in store for me when I actually got my period. I probably wouldn't have wished for it so much, but I remember one of my first periods, I was sitting on the toilet, horrible back pain. I was crying. I was trying to poo. Nothing was coming out. My abdomen was like spasming, and the pain was so bad that I hyperventilated and I passed out. My mom called 911, which is our emergency number here in the US, and the ambulance came. So I remember just from the onset of my period having like really incapacitating pain. And then even when I went to the hospital for the pain, the doctors, they just gave me oxygen and they just said, oh, some people have bad periods. I was, even from the first time we went to the hospital in an ambulance, it was just automatically normalized and dismissed. So from there, it just kept snowballing into this thing that it was like, oh, well, some people just have bad periods. You just have to deal with that. And then about a year later, I just woke up and that kind of same, menstrual pain that I had, I wasn't on my period, but I had that kind of menstrual pain, and it was very confusing. And a couple days later, like I started having chronic diarrhea, very severe chronic diarrhea. My legs started hurting. I had nausea. And really from that day forward, when I was had just turned 17, for the next 16 years, I, had the symptoms that uh, basically devastated my life until I had excision surgery at 33 years old.
All right. So I understand pelvic pain, menstrual pain was something which would have been like terrible. But what are the symptoms that troubled you the most besides the pelvic pain, obviously, which happens during the periods? What is it that troubled you the most?
Yeah, sure. So, I would say that it's hard to pinpoint something that troubled me the most because, like many of us watching, I'm sure I'm one of those people who have symptoms all across the board, all kinds of very severe symptoms. But, I would say when I first got sick for the first 2 years, it was definitely diarrhea. I mean, I had such severe chronic diarrhea from one day to the next. One day I was fine, and then one day I woke up and I didn't feel good. I had no appetite. I was like, oh, I think I have the flu. Started having diarrhea, and it just never went away. I lost a lot of weight and I was very dehydrated. I ended up getting 9 kidney stones over the course of 4 years just from the dehydration from the diarrhea. During that time, I got so weak, I think, from the diarrhea that I had really bad chronic fatigue. I could barely keep my eyes open. I was sleeping most of the day. I couldn't push a door open or go up a flight of stairs. So I think for me, it's been a lot of, yeah, diarrhea. And then after that, like urinary symptoms began, the incontinence, frequency, urgency, like, oh, I really have to go pee right now, right now. So much that I was like peeing behind cars on the street, peeing behind bushes. It was obviously at that time I was very young and I had no idea what was going on. It was really scary and also felt very shameful because they're, problems that have to do with going to the bathroom. And a lot of people think that's disgusting and gross. There's a lot of shame and taboo around that to talk about it. And of course, you go to the doctor and you're too young to be having those symptoms. Like that sounds like stress. It sounds like anxiety. And no one is addressing the real symptoms and the real cause behind it. So you just keep getting gaslit and being told like, you're only 19, that's not normal. And you're like, yeah, I know it's not normal. So do something, and oh, just eat more fiber, just change your water intake. So I think for me, my most troubling symptoms have been around like urinary and um, digestive symptoms and just needing the bathroom for one reason or another. And also going to the bathroom is extraordinarily painful. So that was another thing.
So I'm sure it must have been like really tough having a teenage where you have so much of peer pressure any which ways, and you having these symptoms which probably you can't explain to your friends or people
Exactly.
around you, It must have been like really tough handling the kind of a situation that you were into. I can imagine. So,
Yeah.
yeah. So, Amy, when was it that you were actually diagnosed with endometriosis? So, how many years you waited before your diagnosis happened, and how did it happen?
Yeah. I think like most of us, so too many years went by before I was actually diagnosed with endometriosis. As you mentioned, it took me 16 years. So when I first got sick, I was 17. That was back in 2002. So there was not a lot of information on the internet. There was no social media, people advocating. So, of course, my parents, they took me to the doctor, and I had, because of the diarrhea, I had 2 colonoscopies, an upper endoscopy, so a camera in the stomach. I had a laparoscopy. I had countless ultrasounds, neurological tests, because I had all this brain fog and couldn't think very well. Allergy tests, stool samples, blood works. I mean, you name it, I had it. And then, the doctors just kept saying, you're in excellent health. Everything is normal. Like you look great. Um, I did have a gynecologist when I was 19. I had some chocolate cysts. That's what she said. Oh, you have these chocolate cysts. And they kept coming and rupturing. So I'd have a cyst and then like 2 months later it would rupture. And that happened like 3 times. And she said, oh, I think you might have endometriosis. So let's do a laparoscopy and let's look. I was 19. I think it was in 2004. So she did a laparoscopy, but when I woke up, she literally said, "You have the best looking ovaries and uterus I've ever seen. So you don't have endo." And of course, I didn't know at the time that she clearly was not an expert in endometriosis. I didn't know at the time that, endo doesn't have to be on the ovaries and the uterus. It can be anywhere in the pelvis or elsewhere, like your lung, your diaphragm, etc. So I'm like 100% sure that she, didn't look beyond the uterus and the ovaries from what she told me. She probably was only looking for the classic black powder burns and, couldn't see wasn't able to recognize subtle endometriosis, which is more common in teenagers. So she completely missed it. And because of how old I was, the lack of social media, et cetera, for me, it was like, oh, they looked for endometriosis just like they looked for multiple sclerosis and lupus and, allergies, and they discarded that. So for me, it was like, oh, I don't have endo, and I never thought about endometriosis again. So I just kind of went through my 20s with these really outrageous, brutal, devastating symptoms that completely affected my life, my ability to work, my ability to have relationships, etc. But I just normalized them at some point, and I was like, okay, I guess I don't need to go to the doctor anymore because all the doctors say they don't know what's up, but this is normal. I mean, in my heart, I knew it wasn't normal, but I no longer was advocating for myself. So what I thought was that um, I thought I was just broken. Like I just came to the conclusion that like there was something wrong with me as a person, like as a human being. Like maybe I was being punished by the universe because I was a bad person, or maybe I was just too sensitive, or maybe it was in my head and I was neurotic and I made up these stories about why I was sick. Of course, I didn't know I was doing that. It was just all that dismissal and gaslighting internalized inside myself. And I stopped advocating, which I don't blame myself, because after you go to 20 different doctors and 20 different specialties and they all tell you you're fine, you're fine, you're fine. I mean, it's really hard to keep pushing, especially like I didn't have my family and my, supporting me at that time. So it was just me, and, they're just beating you down, beating you down. At some point, you can get beaten down. And that's what happened for me. But when I was 30, I started having even more symptoms, and, that menstrual pain, that really incapacitating, like I'd be screaming and writhing and vomiting. And I was absolutely terrified of my periods. I definitely had PTSD about them. And when I was around 30, I started getting that pain in other situations, like when I was having sex, or when I was having a bowel movement. Or I remember one time I drank a cold glass of water with ice and I got that menstrual pain. And I started thinking like I was older at that point. I had more life experience, more confidence, more supportive people in my life. And I, started to realize there must be something wrong with me. Like it's not normal to drink a glass of water and then be throwing up and clutching your back and thinking, should I call 911? But if I go to the hospital, they'll just tell me I'm seeking drugs. So I guess I'll just wait. Like this is not normal. So I did go back to gynecologists looking for answers. Two more gaslighters. Oh, just take birth control for that. It's like, really, I have cramps when I drink water. Take birth control, but I did find finally a third gynecologist who said, that really sounds like endo. I think you have endometriosis. And from there, I was able to find more information on endometriosis, learn about how many doctors just have no clue what they're doing with endometriosis. As I'm very grateful that this doctor could suspect diagnosis and give me that empowerment to say, I think you have endo. But the next thing she said was, you should have a hysterectomy, which we know that hysterectomy is not a definitive cure, that endo is not, from the uterus. So quickly I realized I needed to get a better doctor, a more expert doctor. And luckily I was able to find one and then get diagnosed with endometriosis surgically and have excision.
That would have been like a painful 16-year journey. I can completely relate to what you're speaking, because the worst thing is every time you go to a doctor and your reports come normal, somewhere you start thinking that you're imagining all the symptoms. Is it there in your mind? I mean, even because at the end of it, somebody has to believe, some doctor has to believe what you're saying is not made up. It's just not normal.
And
I think
getting a diagnosis is so therapeutic that
it
you
is,
feel so relieved, and people like you start believing yourself actually.
because it's more of a validation with me. It's more of a validation that what you're saying is not made up. It's a fact.
Hmm.
It's a fact. So it can get crazy. So with me,
Oh,
what?
I'd love,
Yeah,
may I make a comment about something you
absolutely,
just said?
absolutely.
Oh,
Most welcome.
okay. Oh, I would just love to say what you said about the validation. I can 100% tell you that after, not immediately, of course, but when I got diagnosed, it was so validating. It's just so validating to see the pictures, to see how sick you are, to see, wow, I had a bowel blockage. That's why I was throwing up, not because of other reasons that people assumed about me, things like that. And I will say that, you know, getting my diagnosis, starting to get believed, which helped other people get me support. Um, I started advocating for myself, like at work, asking for accommodations that I had needed for years that I had been too scared to ask for because I, thought that I didn't deserve them. And so for me, getting validated, I think completely transformed my life because I had such a lack of confidence in myself. I think I actually like self-loathed myself because I was supposed to be fine and normal, but I wasn't. I was sick all the time, even though I was supposed to, quote unquote, be fine. And so I had this such internalized hatred towards myself. Once I got diagnosed, of course I had to work through the process of changing how I spoke to myself and working through that. But my whole life, my whole who I am and my whole concept of who I am changed, and my confidence soared and my self-trust soared. And yeah, I think that having that diagnosis is it's really transformational.
It does. It does.
It does. It does. Brings in a lot of change. And we are glad that even after 16 years of suffering, you could transform your life. There are some women and some people who cannot come out of this.
That's true.
So we are glad that you could fight it back and started advocating it, and you are now helping others as well.
Absolutely, absolutely. That's like a commendable job that you're doing. I was just listening to your podcast, Amy, and it is so wonderful. It is so wonderful.
So gaslighting and normalizing the symptoms should go away completely.
It should.
We agree. Most of the
It should.
patients who come to us, they will say the same thing what Amy has said, that they had painful periods and they were always told that this is normal, you are overreacting, this is in your head, nothing is wrong with you, your reports are normal. So this is where the endometriosis diagnosis gets delayed and the care gets delayed.
And especially in teenagers, I think that's the worst thing to happen. That's
Yes,
the worst thing.
yes.
So
As
coming to,
Amy had a
sorry,
laparoscopy at 19 years. So stage 1 and stage 2 endometriosis lesions, until unless you are trained to look for them, you won't be able to identify them. They are very early lesions, powder burn appearances, or they may be just like vesicles. So it is
correct.
very difficult to pick up on any imaging. A good sonologist can pick up on MRI, but they need a special protocol for that. Even on laparoscopy, most of the doctors may miss it. So that is very important that stage 1 and stage 2 endo is picked up. Definitely she had it and it developed to stage 4 endo. Probably you had a bowel endometriosis because all your symptoms are towards bowel endometriosis. You had diarrhea, you were throwing up, you had constipation. So all your symptoms are pointing towards that. Anyways, glad you got
Uh,
the diagnosis and now you are back on the track.
True. So, Vimi, we were just talking about all these gastric symptoms, the bowel movement that changed, with Amy was indicative of bowel endometriosis, right? So, what exactly is it and how common is it? Also, just tell our viewers what symptoms that a person should actually look out for, that they might have something called as bowel endometriosis.
Okay. Shilpa, I'll share my screen.
Yeah.
I'll tell a little bit in detail so that they understand.
Yeah, absolutely.
You can see my screen?
Yes. Yes, you can.
So basic, what we always start discussion with, major hurdles in endometriosis care, lack of standard of care, gaslighting by medical fraternity and peers, lack of familial support, delay in diagnosis, Endometriosis is not a subspecialty in medical school yet, and lack of excision specialists globally. I think Amy has mentioned all these problems in her diagnosis too.
True.
Now, endometriosis and quality of life, it causes pain and infertility, but it is not limited to that. The real pain is much bigger. Women with endometriosis experience diminished quality of life, increased depression, adverse effects on intimate relationships, limitation on participation on daily activities, reduced social activity, loss of productivity and associated income, and increased risk of chronic disease, significant direct and indirect healthcare costs as well. Now, if we look at the pelvic endometriosis is defined as the endometriosis of the uterus, ovaries, fallopian tubes, the uterine ligaments, and the peritoneum, be it anterior or posterior, pouch of Douglas, and the lateral pelvic peritoneum. Extrapelvic endometriosis, where we are going to discuss the bowel endometriosis, it can affect other areas of body, including vagina, vulva, cervix, perineum, urinary system, GI system, thoracic cavity, lung, pleura, and cutaneous tissue involving CNS as well. Now, extragenital endometriosis, basically, if we look at bowel, the rectum, sigmoid, and the bladder, they are also pelvic organs. But we are not including it in pelvic endometriosis. So it should be called as extragenital pelvic endometriosis, which describes it in a more accurate way, which involves these three organs, the rectum, sigmoid, and bladder. Now, intestinal involvement, as you asked how common it is, if we look at endometriosis patients, 8 to 12% of women with endometriosis may have GI involvement. For our viewers, this is our GI tract where the small intestine, large intestine, rectum, and anus is there. The rectum and sigmoid being the commonest site of involvement. Rectum is this one which lies just behind the uterus. So this is the commonest site of involvement. The small intestine, less common. Rarely it may involve liver, pancreas, stomach, gallbladder, and esophagus as well. Now this is a large intestine which is commonly involved, and basically these two areas are more commonly involved, and it can be up to 90 to 95%, followed by uncommon areas, ileum, appendix, and cecum. This is one of the specimens of appendiceal endometriosis. Small intestine lesions mostly involve the terminal ileum and account for 5 to 16% of GI endometriosis cases. Now, symptoms, a very important thing. One is they may be completely asymptomatic because endometriosis is always a spectrum. The symptoms can be very subtle to a very severe symptoms. Crampy abdominal pain, rectal pain during menstruation, painful intercourse, rectal pain while sitting, diarrhea, constipation, diarrhea followed by constipation, constipation followed by diarrhea. These are very important symptoms. They may be indicative of subocclusive disease. Bloating, partial or complete obstruction can happen rarely. Dyschezia, difficulty in passing stools. Tenesmus, you want to pass motion but you're not able to do it. That feeling is called as tenesmus. Meteorism is buildup of gases in your GI tract. Melena is passage of black stools, diarrhea, vomiting. Hematochezia is passage of fresh blood in stools, pain on defecation, pain after meals in the rectum. So these are the common symptoms which may be noted, not that everyone will have all the symptoms, or they may be completely asymptomatic as well. When the serosal layer is involved, symptoms may be same as pelvic endo. Like they will have painful periods, they will have dysmenorrhea, or whatever the symptoms of the pelvic pain can be there. They may not have specifically bowel symptoms. Similar to pelvic endometriosis, the severity does not correspond to the extent of the disease. As in pelvic endometriosis, stage 4 patient may be completely asymptomatic, and stage 1 patient may have very severe symptom that they can't even sit. So likewise in bowel endometriosis also, symptoms do not correspond always to the stage of the disease. So these are the common symptoms which one should be careful, keep a watch on this. And this is basically just to explain why it causes pain when patient pass motion, when they have lesions either on the surface or in the bowel. So these lesions, this is the uterus and this is the intestinal tract. This is the endometriotic lesions which are inflammatory and They cause a lot of fibrosis, adhesions. So when stool passes through them or it touches, the area is so inflamed that you get pain or you have difficulty passing motion, because sometimes these lesions may extend into the lumen as well. So that causes subocclusive disease, and their patient symptoms will be very severe. Shilpa, you're mute.
No, I was wanting to check, is there something else that you wanted to talk about?
No, you asked about symptoms and bowel endoscopy. Just finished that.
That's what. Fine. So we have just seen what exactly are the symptoms and what is it to have bowel endometriosis. Now, my next question is, how is it diagnosed and how many patients, how is it diagnosed, first of all? And second thing is, what I've heard of is a lot of people are advised colonoscopy, right? So is it advisable? Is it visible on colonoscopy?
Usually no, Shilpa. I'll again tell the details. I'll share the screen again. So basically, how to diagnose, one is the approach to endometriosis patient has to be a little different. We have to listen to them, elicit the proper history, different pain types, visual analog score of all the types of pain and location should be elicited. Examination is a very important part, and then comes the imaging and plan of management. Now, clinical history, pelvic bimanual examination, and ultrasound. These are the first line of diagnostic ways. Examination has to be complete and thorough. We look for masses, we look for hyperalgesia, muscle tone, tenderness, previous scars or injury, any nodularity in the fornices, cul-de-sac, uterosacrals, mobility, axis. The uterine axis, if it is retroverted or retroflexed or anteverted, antiflexed, that gives us a lot of information. Any neurological patterns of pain or sensory deficits. Pelvirectal examination may help identify rectovaginal fullness or nodularity. Speculum examination help us in identifying the vaginal nodules. So this in all endo patients is very, very important. Sometimes patients have very, very severe pain. They don't allow pelvic examination, and we do respect that. Sometimes during anesthesia, we check that, or our sonologist gives us the complete information and then we can take it forward. So this is a picture which just tells us how we do a bimanual examination.
Okay.
Now, if we come to the scans, we have transvaginal and transabdominal scan. It should be endometriosis protocol should be followed for scans. For our scans, we usually give a laxative 1 day prior to empty the bowels completely, and we take them for a scan. If a sonologist is trained to look for endometriosis, actually ultrasound can pick up maximum lesions other than stage 1 or stage 2 endometriosis. For that, MRI can be done. Bowel nodules, uterosacral nodules, and rectovaginal nodules can easily be picked on ultrasound if they follow a dedicated endometriosis protocol. Now, MRI is highly efficient and accurate with a sensitivity of 88% and a specificity of 98%. It has a very high sensitivity, but again, MRI also, we get a lot of negative imaging. Now, if the person is not trained to pick up those lesions, or a dedicated MRI protocol is also not followed, you will miss all the lesions. We get many patients who send us their MRI. There is a clear-cut evidence of endometriosis, but the report is normal. No evidence of endometriosis noted. So these are the pitfalls where we can, until unless they follow the dedicated protocol, they take the images in certain sections, they don't follow the TW1, TW2 imaging protocols, we even cannot pick up on MRI the early lesions. So these are the important things. That is why the IDEA group, international group on endometriosis imaging, they want to have a common language, common nomenclature, so that everybody uses the same terminology, same nomenclature, and the reporting is given in a proper manner. It will be uniform. If they start the scan, they will start with the abdominal scan, they will look for liver, perihepatic spaces, they will look for all those things. then followed by a vaginal scan. In that, they will look for uterus, ovaries, cul-de-sac, sliding sign, everything they have to follow step by step. Then they can pick up all these things. And ultrasound is very sensitive if the person who is doing the ultrasound is trained to look for endometriosis. So basically, when they should follow like anatomical landmarks. They should look for anterior compartment. All these features they have to see. Posterior compartment. They should look for each and every compartment, and if they do it compartment wise, and abnormal areas will not be missed. So this is what the international group, the IDEA group, has given the guidelines, but still it is not standardized that everybody is following the same protocol. It's not happening. If that happens, we will have a standard nomenclature, standard reporting system, and endometriosis can be picked up at many of the centers there. So this is these are the layers of the bowel actually, the serosa, and then the longitudinal muscle layer, the circular muscle, the submucosa, and the mucosa. And if you look at this image, this is an ultrasound image. If done properly, they can see all the layers of the bowel. So if they know the normal anatomy, there is no point that they should miss the abnormal tissue there.
True.
So these are some of the images where bowel endometriosis is there. You can see very nicely shown in these images. Sometimes they give a diagnosis of rectal polyp, cancer, diverticular, Tallow cyst. So many diagnoses comes, but they have to keep in mind that endometriosis grows from outside to in. And these are the growths from inside to outside. So this is the most common differentiating features where we can differentiate endometriosis from other. So what information I as a surgeon need in cases of endometriosis scans or MRI? I need to know the extent of lesion, whether it is multifocal or satellite, depth of invasion of the muscularis, the circumference involved, less than 1/3, 2/3, or more than 2/3, so that I can decide whether I'm going for discoid excision or I'm going for the segmental resection, so that I can counsel my patient accordingly. The number of lesions, multiple lesions, there will be different approach. Single lesion, size of the lesion, very important for me to decide the treatment approach. Vaginal and parametrial involvement is important because if we do the segmental resection or discoid excision, there will be, and if there is a vaginal involvement, there may be two suture lines which may overlap. So that also has to be decided pre-surgically or during the surgery what we are going to do. The distance from anal sphincter to guide surgical decision making and provide appropriate counseling to the patient. If the distance from anal verge is less, then resections are a little difficult. If the distance from anal verge is sufficient and we can do a segmental resection, the outcomes are good. So distance from anal verge of the lesion also helps us counseling the patient and deciding the surgical plan. So these are the, this is information what I should get in my imaging. This is something like this, like primary posterior compartment involvement with thickened rectovaginal septum, bowel thickening up to a length of 64 millimeter with 22 millimeter depth extending up to mucosal surface, 50% of the circumference involved. So such kind of reporting helps us decide our plan. And this is really helpful when we take endometriosis patients for surgery. Now, this is one of the MRI pictures, how we can locate the lesions. Now you asked me how colonoscopy is not helpful. The colonoscopy does not help because I already told the endometriosis starts from outer surface to inner surface. And colonoscopy is primarily to look into the lumen of the colon. Right. So sometimes if it is subocclusive disease or if it is going inside the mucosa, then we may pick up, but hardly it happens. It is usually above the mucosa most of the cases. So colonoscopy is like, it is little embarrassing procedure for the patients also. They don't like it. And scientifically speaking, it does not help much in our management. So it does not help doing a colonoscopy routinely for all patients. If you are suspecting a very big lesion, occlusive disease is there, or you want some biopsy before you go ahead with the surgery, some other pathology is suspected, then definitely colonoscopy helps, but not for bowel endometriosis per se.
All right. So when I was diagnosed with endometriosis, okay, before I got diagnosed with endometriosis, I was told that I'm having IBS, like your slide just shows. So I was being treated for IBS for years at a stretch, having all the symptoms of bowel endometriosis. And suddenly I developed a block in the intestine and I landed up in the OT. All right. So now, my next question is, why is bowel endometriosis so commonly confused with IBS?
See, one is the symptoms, uh, the bloating, gaseous distension, diarrhea, constipation. IBS can present with all these symptoms.
Hmm.
And it is added with the negative imaging. When you don't have any diagnosis, they stamp you as IBS because they cannot pick up endometriosis and they have not picked up yet. So these symptoms, they don't find any other pathology. They will do upper GI endoscopy, they'll do lower GI endoscopy. You'll be referred to at least 6 to 7 specialties. You go to, for pain, you go to GI, medical gastroenterologist, then surgical gastroenterologist. Then they will evaluate you, they'll do endoscopies, both the endoscopies, they don't find anything. So ultimately, they put you in the category of irritable bowel syndrome. Your bowel is irritated, you avoid such kind of foods, you get diarrhea, you get constipation, you get bloating, you get flatulence. So all these symptoms, the symptoms are same as endometriosis, almost same. But the evidence is lacking that you have endometriosis. So if you have a good imaging, I think you can nullify this diagnosis.
Or else you end up getting into the emergency room.
Yeah.
Okay, so what's the treatment? What's the treatment for bowel endometriosis?
Treatment is excision. We always talk about excision. Whatever is there, we have to remove the disease, not the organ. Like Amy was advised hysterectomy. So hysterectomy is not a cure for endometriosis for all of you. If somebody advises you hysterectomy and you don't have adenomyosis, then that's a red flag. So you should discuss with your doctor or seek another opinion.
All
So
right.
excision is the treatment, but treatment has to be tailored according to patient symptoms and wishes with a view to excise as much disease as possible while preserving the organ function. So here in bowel endometriosis, it is very, very important that radicality of procedure is tailored to the patient needs or her disease. And radicality of the surgery is associated with lower recurrence but a higher risk of complications. So that we have to keep in mind, and we have to counsel the patient accordingly. Now, the treatment options for bowel endometriosis in very simple line diagram, I'll just explain so that our viewers understand the concept. If this is an endometriotic lesion, which is on the serosal surface, just on the serosal surface, we can just shave it off. That is called as shaving. When it is going into the inner layers, discoid excision is an option. And if it is going up to the mucosa, then segmental resection. But again, it depends on so many factors when we decide for the discoid and when we decide for segmental resection. Now, if you look at this picture, this is a lumen of the bowel. So if we divide it into 1/3, 2/3, and the circumference, so how much circumference is involved, that is important for our decisions. Now, this is a superficial lesion, shaving helps. Now, this lesion is going into deeper, but it is less than 3 centimeter. So we can opt for discoid excision. For such lesions more than 3 centimeter, segmental resection, we need to cut this segment and rejoin these two ends. That is called a segmental resection. Now, such lesions are also called as, this is satellite lesion and this is multifocal lesion. So here there are two lesions separated by a distance of more than 2 centimeter. In that case, segmental resection has to be done. And these are multiple lesions separated by less than 2 centimeter, but again, it will land up with a segmental resection. So this is how we decide what kind of resection or what kind of excision we are planning for the particular patient. Now, every treatment has its own benefits and risk factors involved. Now, shaving can be done easily with, it is the least invasive method. This is the bowel. This is a laparoscopic picture where the bowel is adherent, and she had a shaving done. Least complications, superficial lesions can be removed. A little recurrence can be on the higher side with shaving, but if completely removed, shaving is also complete excision for lesions on the serosa or the superficial lesions. Different energy sources can be used, or cold scissors can be used. Among the energy sources, we usually use harmonic scalpel, but different surgeons have different preferences. They can use lasers or plasma jet. CO2 laser is also available. So different energy sources can be used for doing this. Now, discoid excision, as I said, the lesion is less than 3 centimeter and the invasion is above the mucosa. So what we do is we cut it is not the complete section of the bowel is removed. If it is on the anterior, this thing, if you suppose, just a portion of disc is cut, like that lesion is removed and both the ends are joined together. This is done with the help of a stapler. First we remove the major nodule and then we put a suture in that, and this suture goes inside the stapler. And we do all this in the presence of a GI surgeon, a colorectal surgeon, and they usually fire the stapler and then both the ends join together again. The segmental resection, it is for the bigger lesions going up to the mucosa. The length of the lesion will also be more. The circumference of the involvement of the bowel will also be more. So this patient had a segmental resection done, in which we almost remove 8 to 9 centimeter of the segment of the colon. So this is how we decide what treatment option we are going to do, and every patient has different types of lesions and different type of treatment. Now, segmental resection is the most radical of these procedures, but if the lesions are bigger, the discoid will not work because there is a limited capacity that the stapler can take. So bigger lesions we cannot do and rejoin the bowel loops. So segmental resection is opted for those cases, but recurrences are very less with segmental resection. Post-operative complications can be a little on the higher side as compared to the shaving and discoid excision. We have to observe for post-operative leak, closure of the lumen or the stenosis. It's very rare, but yes, we have to keep a close watch on these complications when patients undergo segmental resection. Now, this is a patient who had prominent bowel symptoms, nothing else. But her bowel was very, very clear. So here I would like to tell that you may not have bowel nodule, but you may have bowel symptoms. So she had she had an endometriotic nodule at the torus uterinus, which is an area where the uterus arterioles arise, the posterior surface of the uterus. And this posterior surface of the uterus lies directly onto the bowel. So whenever she passes motion, she has pain because of this nodule inflammation. So and also there is a pitfall on ultrasound. Sometimes they give us as bowel nodule, but it is on the uterine surface. So here we counsel the patient that we might go for discoid excision if the bowel nodule is there, but bowel was absolutely clean and clear. There was nothing. So we excised the nodule and her bowel symptoms came down and she's doing good. Now this is just to for our viewers to understand, this is how the uterus looks on laparoscopy. This is the uterus, these are the fallopian tubes, these are the ovaries, and this is the bowel. So this is basically opposite of what we see on the ultrasound. This is how it looks, and then after adhesiolysis and all, we restore the anatomy and excise whatever lesions are there in the pelvis or anywhere. So the crux of the thing is that it has to be a multidisciplinary approach whenever you are dealing with an endometriosis patient. It's not only that I'm taking you for the bowel endometriosis or I'm taking you for the chocolate cyst, I'll remove the chocolate cyst and come out. So we counsel the patient that wherever we find the lesions, we are going to remove them, be it under the diaphragm or anywhere. So we usually, we should have a team approach for endo patients where any lesions found, suppose it is on the diaphragm, we should have a thoracic surgeon available, and we should handle it at the same moment. And we should not subject the women for surgeries again and again. So if this is followed all over the world, I think world will be a better place to live in for endo patients.
True that. Completely. And this was like quite descriptive and it
And
was in detail.
all this happens because of my team. This is the team we have. We have urosurgeon, we have colorectal surgeon, we have anesthetist, pelvic PT, nutritionist, everyone is there.
True. That makes sense. And it was like quite detailed. Thanks, Vimi. This was like quite informative.
Thank you.
So I obviously had a segmental resection of my intestine, and it was like crazy. I still remember, and I still can't get over the kind of a pain that I had. Oh my god! But trust me, it's okay. Whatever happens, happens for good. So Amy, uh, coming to
Oh,
endometriosis,
I'd
yes,
I'd love to make a comment about Dr. Bindra's presentation.
yeah,
Oh,
please.
first, I just want to say, wow, that was really detailed and really thorough and really easy to understand. So thank you for that, because, I think as endometriosis patients, we really want to understand our disease, our body, our treatment, and there's just so much misinformation. And then additionally, when you look things up, like those diagrams that you put up were so clear, because it can be very hard to like understand the different layers of the bowel and the different treatments. I did want to ask you, so I actually also had endo on my small intestine. I had both the large and small intestine. So I was wondering, with endo on the small intestine, is it the same treatment like the shaving and the discoid resection and the bowel resection, or how do they
It is
remove it from the
uncommon. It is
small?
not that common, Emmy, as large intestine, but the treatment will be same.
Okay.
Give the bowel preparation completely, and the treatment will be same. They have to. If it is a larger segment involved, then definitely it has to be a segmental resection.
Oh, perfect.
Good. So Amy, coming to you, how does endometriosis affect a person's mental and emotional health? I mean, you have been doing a lot of podcasts. I heard about your I heard your podcast, and you do deal with this. So tell us a little about this.
Yeah, sure. So, I think, well, I think we all know when we're living with endometriosis that it's really taxing on us emotionally and, of course, physically. And I think, with our mental health, it's with endometriosis. I mean, first, we're dealing with this really unpredictable nature of our flares. We don't know how we're going to feel from one minute to the next. And then, of course, we already talked about the medical trauma, the gaslighting, the dismissal, lack of support from the people around us. And then I think also there's, the physical symptoms can bring a lot of trauma to us. I mean, if we're dealing with infertility, I think there's a lot of grief. If we're dealing with incapacitating pain, there can be a lot of fear around, basic everyday functions, menstruating, eating, going to the bathroom. I think that so much is taken away from us. And I think, when it impacts our ability to work, then of course we can have social isolation, we can have a financial concerns. If we're not able to leave the house, if we have to cancel plans, we can feel like a burden, like a bother, like we're not a good friend. So I think there are so many ways that this disease can impact our mental health. And I do also just want to point out that, for people who have identities that have been historically marginalized, they can have even further trauma. So, medical professionals and others can have implicit and explicit biases, and they can hold them towards people in terms of race, ethnicity, gender identity expression, sexual orientation, and all of that can affect our ability to get diagnosed, to get the proper treatment that we need, or just be treated with decency like the human being that we are. So I think that the mental health impact of endo is it's just not talked about enough. And, some research has shown that living with chronic pain can take a similar emotional diagnosis as a emotional toll as a cancer diagnosis. And, I say this to just show the seriousness of of living every day with the daily onslaught of pain and symptoms that so many of us have, that it is, the emotional toll is very serious. And I think sometimes, I know my own case, like I underplayed that. I think many of us underplay that because of all the gaslighting and all the dismissal. Sometimes we push our feelings aside, or we tell ourselves to suck it up, or we have to keep up with this ableist world, even though our body can't keep up. And so I think there can be some layers of subconscious gaslighting and dismissing ourselves because we've internalized the gaslighting that we've received. So I think it's just really important to realize that living with endo is really really difficult, and it's okay to feel our feelings. It's okay to see a mental health professional. In fact, I think I think when we get diagnosed, that should just, be part of the be part of the care team that we have, the excision surgeon, the nutritionist, the pelvic floor therapist, the mental health professional. I think that um, we should really take steps to recognize the psychological and emotional impact that it's had on us, and that's not easy, but to work towards having a healthy relationship with ourselves, changing our self-talk, having healthy outlets for our feelings, working safely through our trauma, and just trying to reaccess the joy and the meaning and the happiness in our lives, where endometriosis can definitely take all of that away. But how can we get that back? How can we live well with this illness, and how can we work through all of the trauma and all of the impact it has on us?
Absolutely. So understand, I can completely agree to what you're saying about mental health. It's not easy dealing with pain every day. So for a person like me or you who has been going through situations, going through this chronic pain since the time we were like teenagers, what do you suggest a person should do to cope up with this kind of a debilitating disease, which is more or less dismissed by most of the people because we look normal, we don't look sick. So how is it that you should actually deal with it? How do you cope up with it?
Yeah, I think it's really hard because I think it is really hard to be so sick and then constantly having people telling you that you look fine and you look normal, or you're too young to have that. Or I think there's a lot of judgment from people. I think we've all faced judgment. Like, I can remember a time when I was in college and I took the elevator to the second floor because I had so much fatigue, but people didn't know that. They just thought I was a 19-year-old sophomore in college, and people in the elevator who were going higher up, to the fifth floor, sixth floor, they rolled their eyes when I got off. They called me lazy. They didn't know that I literally couldn't walk up a flight of stairs. And, so I think it's really important because there's so much gaslighting and dismissal with endometriosis. And I don't know if that's true for other illnesses, but it's definitely true for endometriosis, both from the medical provider and from the loved ones and people around us, that I think it's so important to find people that truly understand what we're going through. I think this could be a friend or a family member, or sometimes just even the endo community on Instagram or Facebook or Reddit, like people who can support us and believe us, who don't doubt us. I think that those are really powerful words when someone just looks you in the eye and they say, I believe you, because what they're saying is, I see you. I see you as a human being. I see your suffering. I see what you're going through. And that validation, that support, I think can actually help us to learn to rehab that trust in ourselves. Because I know my own case, after all these years of gaslighting and misdiagnosis, I really came to second guess myself. I really internalized that maybe I am lazy, maybe I should be doing this differently. And I think then you can have a lot of shame. I had a lot of shame. I had a lot of self-judgment. And then that spiral of criticism can take over in your mind, and the names you can call yourself and the way that you feel about yourself. So I think first, seeing if you can find outside support. And like I said, even if in your personal life, maybe is no support. I do understand that. I didn't have support in my personal life for over a decade. But for me, finding the endo community on Instagram was, really life changing because I met people who were going through the same thing who believed and supported me. And that helped me learn to have kindness and self-compassion for myself. And I think that is really important, is just learning to be kind and compassionate with ourselves, reminding ourselves that other people, they don't understand what it's like to live with this disease because they don't have it. They don't see what we live with. They may not know we have endo, or they may know that we have endo, but they may not get it. So they may still judge us even though we explain to them that we're fatigued and that's why we're using the elevator. But I think we can't control what other people think,
True.
but we can work on what we think about ourselves. We can, and it is a process, and it takes time. So it's not like overnight, suddenly you're just like, yeah, I love myself. But I think we can work on how we feel about ourselves through our self talk, through trusting ourselves, through, saying, okay, you know what? I do have to use the elevator because I have an illness, and, and that's okay.
All right, that's beautiful. Actually, self-love, what I have realized, doesn't happen in one day. It's a practice that you really have to do every day, and that's when you would really learn how to practice self-love. So, tell us a little about your podcast in 16 Years of Endometriosis. What does it talk about?
Sure. So I think you gave a pretty good summary before, but I mean, basically it's me, it's my best friend, Brittany. Brittany does not have endometriosis that we know of, but she does have terrible hormone period problems, PCOS, nausea, anxiety disorders. So between the two of us, we're a mess, and we have a collection of like 12 illnesses. And we basically just get together twice a month, and we just while we educate. I think first and foremost, it's an educational podcast. We look up factual information about the disease. We really pride ourselves on having correct information, and then we give that information. We give tips on excision surgery, hormones, treatments, living with endo, empowering yourself, self-limiting beliefs, all of the things, really everything that is kind of relevant in our lives with endo. We tried to touch on so many different topics, but because it's a chat show with my best friend, it's really fun. Like we chat, but we have fun. We yell, we cry, we scream. We both named our illness. My endo is called Red Dragon. Hers is called, her uterus problems are with her period is called Mushu. So it's a really fun podcast. And what I've heard most is that we've made learning fun. I've heard that a lot. And I've also heard that, we've helped people feel not alone, and we have absolutely no holding back, no filter, no shame. So I talk about times when I, pooped myself and then in my bed and laid in it. Like I, talked about times when I got flares and at my work, and I, was found crawling in the bathroom with vomit all over my shirt. So I think it's really important that there's so much stigma and trauma around having illnesses like endometriosis, like problems with your bowels, bleeding, that we want to remove the stigma. So it is a safe space to talk about all these topics, and we address mental health a lot because that's really important to us.
Absolutely. It's one of the most important things to do, and love your podcast. It's like I would recommend everyone who is going through some symptom of endometriosis or anything related to it, please go and watch her podcast. It's like lovely. Um, so now you have also authored a book, right? Finding Peace with a Devastating Disease. What's that about? How did you go about writing a book?
Sure. So I always had this dream to write a book. I actually started the book like 5 years ago, but I think with endometriosis, there are some dreams that maybe we're not going to be able to fulfill, but there are some dreams that we can fulfill, but they'll just take longer than we thought. So it took me about 5 years to write this book, slowly writing it over time, when I wasn't feeling sick and in the toilet, etc. But it finally happened, which I'm so proud of. But basically, um, the book it's 76 reflections, where I address emotional aspects of living with endometriosis, where I talk about my search for finding peace with endometriosis, because I was 16 years without being diagnosed. I started the book before I was diagnosed, before I knew I had endometriosis. I started it like 3 years before I had my diagnosis and had excision, because I got to the point where I started having reactions to the NSAIDs, the non-steroidal anti-inflammatory pills like Aleve and naproxen, things like that. They were the gastrointestinal side effects were, it was like I would take one, I felt like I swallowed a glass. That feeling wouldn't go away for a week. It came to the point where it was like, I need these pills to survive my pain, but then they give me like severe. I got diagnosed with severe gastritis. It became this like terrible rock and a hard place where it was like, these are the only pills. I work with my doctor, nothing else would get rid of the pain. No other. I tried so many different kinds of painkillers, very strong stuff, but nothing worked. And I realized, if I was gonna, my mental health was just, I was in such a bad place. It was like, if I don't, somehow I have to learn how to accept this lot that life has given me, because if I don't know how much longer I can go through this and how much longer I can be here. So the book really outlines my journey to try to find acceptance with this horrible disease. Endo is a devastating disease, and I put that right in the title because I really wanted people to feel seen. I really wanted people to feel understood, to know that I'm living it with them. Like, endo is devastating and heartbreaking and incapacitating, and finding peace and acceptance is not easy. It is not easy to find peace and acceptance with something that has taken away so much from us and is causing us pain, incapacitating pain every single day. So, the book is really an exploration of learning to find joy again in my life, learning to find meaning in a life where it feels like there is none, reframing my beliefs about myself, about who I am as a person with an illness, that I'm not a burden, that I'm not unlovable, that I do deserve to be happy, that I do deserve to feel better. So it's really just like lessons that I learned as I started shifting from, really actively hating my life, hating my body, hating my endometriosis, to trying to just feel less angry, feel more neutral towards everything. And then, ultimately trying to figure out how I can live well. How can I like my life? How can I mean, dare I say, how can I love my life even though I have this illness? And of course, I don't love my endometriosis. It's not, yes, I love my chronic pain, but it's how can I just take the good, the bad, and the ugly, so much ugly. How can I take the good, the bad, and the ugly and embrace it all and still have joy and still have a good life? And um, so that's really what it's about. And it's my own journey, but at the end of each reflection, I have self-guided journaling prompts for the reader. So if they'd like to explore their topic on their own, where I talk about my feelings of being a burden and how I try to work through that, then I provide questions for them to try to work through their own feelings of being a burden if they have them, or their own feelings of, where can I find joy, or how can I accept this circumstance? So it's an interactive book. It can be read on its own, of course. It's a beautiful book, but it also has an interactive component, and um, I do think it is a good tool among many other tools for emotional healing with endometriosis.
That's so beautiful. There must have been a lot of thought that would have gone into actually making the book so interactive. Uh, so, so Vimi, one last question to you. How, in your view, should the doctors deal with endo patients?
Uh, Before I give that answer, Emmy, I would like to tell that you asked me about small intestine, right? So the discoid excision cannot be done with a stapler there, okay? Because a stapler is introduced from the rectum. So the same thing can be done if the lesion is less than 3 centimeter and the circumference is less than 1/3 involved. Then the same like disc-like thing will be cut, and then we suture it. It is also discoid actually, but it is not done with a stapler. That is the only difference. Otherwise, whichever lesion is there, depending on the size and extent of involvement and the circumference, we decide for the segmental or shaving or the excision of that nodule. Just wanted to clarify that discoid cannot happen with the stapler in the small intestine. Coming to how we should approach the endo patient, first thing is listen to your patient. Anamnesis, we call it anamnesis. You just have to listen to the patient. When endo patients, they come with 6-7 files, they just keep on talking. We don't interrupt for first 10 to 15 minutes. And they feel so relieved. They say, doctor, first time somebody has heard me. So that acts as a healer for endo patients. So listening is very important, and then comes the technical part of our history taking, examination. I think in my first few slides, I mentioned that a proper thorough examination, the relevant imaging, and then counseling the patient. And even if we don't find anything on the imaging, we never dismiss the patient. We never tell them that it is not normal. We just try to find a diagnosis for her pain. So that is how we should approach to the patient. There should be a proper consultation time for the patient. We should give them enough time. Endo patients cannot be seen in a hurry. They really need time. We need to look at their findings, the symptoms. They may have a whole lot of symptoms which they don't even realize. Now, fatigue is one of the common symptoms. The patient may not tell us that fatigue is there. But while eliciting, when we ask them, they say yes to most of the symptoms which we tell them. Do you have bloating? You have fatigue? You feel tired all the day, even after taking rest? They say yes to all this. Sometimes patients do not come with these symptoms. They do not realize that this can be because of endometriosis. They come to us with pelvic pain most of the time. Now, Amy is educated. She knows endometriosis, so she can correlate that, yes, it happens because of endometriosis. But the new patients who have been just started having symptoms, they may not even realize. So these are the things the patients present with some symptoms, and there are some signs which we should ask them that whether you have this or not. So detailed history, detailed examination, imaging, listening to them, talking to them, and giving them a right diagnosis, counseling, and a multidisciplinary approach. This is how we approach our endo patients. And post-operative, now surgery is one thing, Shilpa. The surgery is only one part of the endo management. It does not complete your treatment.
True.
Okay, your pain completely won't disappear all of a sudden after surgery. It really improves, I agree. But there are a lot of changes you should do in your lifestyle, the nutritional counseling, the pelvic physiotherapy, and for their mental well-being, they should also have a psychological support and counseling. These are the things which should be taken care post-operatively. It's not that surgery is done and we are done with the patient. So that doesn't happen with our practice. They are usually in touch with us and they keep following all these things. And we keep evaluating them every 6 months or a year, and will this thing for the recurrence, because recurrence is also one thing which endo patients may have, and then we should look for it at the earliest. So this is how we should approach a patient. Stop gaslighting, stop normalizing the symptoms, and we should start validating the patients, whatever they say. We should agree with them. If they say something is wrong, we should at least try to explore what's going on. So this is how we should approach endometriosis. And yes, endometriosis is not only confined to ovaries. There are few things which are wrong notions. All those myths should be busted. Painful periods are not normal. Hysterectomy is not the cure. Pregnancy does not cure endometriosis, because most of our patients, they are told that you get married, have a child, and then you will be sorted out. So that should not be told to the patients. In India, especially when a patient's ovaries are involved, it's a big thing for the whole family, not only the patient. Patient cannot decide that she will undergo a surgery unless she has a really strong foothold and she can talk about it. So the whole family decides for it. So there, the parents always want that she should get married and have a child. So sometimes we also get stuck, and then it's not that only doctors tell us. Sometimes parents also come and tell us that we don't want to get operated. We want her to have a child and have a baby and then get operated. So it's not like that. Endometriosis is a progressive disease. It should be dealt with at the earliest so that we can stop the progression and involvement of other organs, because we don't do endometriosis surgery at early stage, then it will involve your all the organs. The fertility potential also comes down. Her stage 2 endo, by the time she gets married, have a child, it may become stage 4 endo. Her ovarian reserve may reduce. So there are so many things involved. So all this involves we should have a 360-degree approach. We should talk about their fertility. We should talk about their pain. We should talk about their family support. So we should treat them as an individual. We should look at that women or an endo patient, how she feels when she has pain. So first we should look at that. Now endometriosis has various aspects also, I would say. There is a silent endometriosis as well. Now patient does not have any symptoms. They just come for fertility evaluation and diagnosed with endometriosis. Now they are not bothered about pain or anything. They don't understand what endometriosis is. They only want a child. So there are two aspects of it. Those who have pain, definitely they will come to us. They need immediate treatment and all those things. Pain and fertility is another aspect. Some people have pain and fertility, so they are looking for both the solutions. They want pain relief as well as they want good fertility outcomes. And there are patients who don't have any pain at all, only looking at fertility. So they don't understand what excision is. Now, if I tell them that bowel will be involved, bowel surgery may be involved, your hospital stay will be more, post-operative complications will be more, they also get confused. Why so much? Just to have a child. Why you are not operating only on the ovaries? So we also face some hurdles to counsel them and tell them, because when a patient has pain, her approach to the disease is different. When they don't have pain, the approach to disease becomes different. So this is how we deal with them, and also we deal with by this way by educating. So I and Shilpa have been doing it for more than a year now. We have been doing these sessions, and it is helping them and creating a lot of awareness. So we are educating patients so that they can take their right decisions and advocate for themselves.
True. Amy, any parting words for our viewers?
Yes. Well, first, I just want to say this was a really excellent live. So thank you for all of the information. It was so helpful and informative. I'll definitely be letting everyone know to watch the replay. I do think when Dr. Bindra was talking about, how I really like how, obviously she's an expert. She's a really qualified, experienced, skilled doctor. And the problem is that so many doctors aren't when we're seeing them for endometriosis. So, you may have to see as a patient. I mean, I probably saw like 40 doctors before they realized I had endometriosis. Even I saw that doctor who told me via laparoscopy that I didn't have endometriosis. Complete BS. I've had other doctors in the past who told me, oh, your ultrasound's clear, you don't have endo. But of course, a clear ultrasound doesn't mean you don't have endo. Endo doesn't always show up on the ultrasound. So there's so much misinformation out there. There's just so many. It's unfortunate because we go to the doctor and the doctor cannot recognize the symptoms because they lack the education or they're misinformed. And so I think it's so important that we should just keep trusting that we know our bodies well. And, I think telling the doctor all of your symptoms is so important because, if I didn't make a connection for a long time that all of my symptoms were related. I thought they were all separate and all different. Yes, I had these like really awful periods with these really awful symptoms, but that in my mind had nothing to do with my diarrhea, which had nothing to do with my fatigue, but they were all connected. And I remember I got my diarrhea somewhat under control after really doing an overhaul of my diet. And it took about 4 years, and my diarrhea said it was like pretty controlled in my day to day, but then I would get the diarrhea back on my period. Like the whole time, that I was bleeding, the diarrhea was so intense. Sometimes I'd be in the hospital for dehydration from the diarrhea. And I remember I went to a gynecologist. I said, look, my period comes. I was getting fevers, swollen lymph nodes on my period, mouth ulcers, really outrageous diarrhea. And the doctor said, diarrhea is not a symptom of your period. Fever is not a symptom. And fast forward, so that doctor was so ignorant, but I didn't know. And, fast forward 10 years later, when I was being seen by an excision expert, I told him all my period symptoms. He's just nodding away like, yes, 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 that is all absolutely, part of endo. And then I even told him, this is going to sound really weird and I hope you don't laugh at me, but on my period, I broke my foot a long time ago. And on my period, my foot pain comes back and I limp during my period. And I know that sounds weird, but it's been happening for 3 years, every period. I swear this happens. And he was so, another doctor would have probably laughed at my face and been like, what does a foot pain have to do with your period? But this doctor said, wow, you made a connection between endo inflammation, full body systemic inflammation, and your foot. So I commend you. And so when you have a doctor who is knowledgeable, they applaud you for realizing these things about your body. But when you have an ignorant doctor, which unfortunately I think is like 95% of them with endo, they're dismissing and laughing in your face. So I just really want to tell the audience to keep trusting in yourself, keep a diary of your symptoms, keep a log. And if you go to the doctor and you give them a list of your symptoms and they go foot pain, diarrhea, and they laugh at you, don't internalize that. Just think in your head, this person is so ignorant. I need to find another doctor, which is not always easy. Of course, it's not easy to hop from doctor to doctor. It costs money, insurance hurdles, access. So it's not an easy fix, but it's unfortunately, I think it's all we can try to do, and that can take time. I mean, it took me 16 years to finally find the right doctor, but don't give up on yourself. Don't give up on getting diagnosed, and don't give up on feeling better. And, of course, excision is I think the cornerstone of the multidisciplinary treatment. But even if you have excision or can't get excision yet, there are other things that you can address in your health. You can try to address your pelvic floor with a pelvic floor therapist. You can try to address the mental health aspects. You can try to address your diet, your lifestyle, your sleep, your stress management. There's so many aspects to how we feel. And I think that's what I've been realizing, post excision. I was very lucky to have excision, and I had a huge, huge reduction in my symptoms. Huge, I mean, life-changing, but I still feel like garbage every day. That's not to not put hope out there. I'm so happy I had excision. I feel less like garbage than I did, but I still have so many things to work on, because I still have to work on, actually learn that I have SIBO. So I have to work on, my gut health. I lost an ovary during excision to an endometrioma. So my hormones are all over the place. So I'm still tackling all these issues, but year by year, I'm improving, so there really is hope. And that's my own personal case. Sometimes people, have excision and it, maybe they don't need to do as many things after that. I've had excision and need to do many more things after, but I think don't give up. There's still so many, different aspects that we can address in our health.
Lovely. Thanks, Amy. It was such a lovely session. I'm actually losing words. It was such a lovely session, so emotionally charged and very educative. Thank you so much, Vimi. Thanks as always. I think this has become a mission for us.
Informative, and when other people hear such stories, definitely it gives them more hope, and they can also validate themselves. They start believing themselves. Yes, there is something wrong, and there are people who are like them. So
absolutely, loads of them like them, actually.
And it can be life-changing for someone.
Yes. Thank you so much, Amy.
Experiences.
Yeah, thanks a ton. Thanks a ton for being our guest. It's been like a pleasure. Yeah. So thank you everyone who's watching this and who stayed with us for more than an hour now. And it's been like a extensive session. And we will be back again for another informative session on endometriosis. Thank you and have a lovely evening ahead. Bye.